Take a deep breath, exhale, and join us for this episode of Hope Out of the Darkness.
Shelley Pavlis is a non-professional learning to navigate the world of suicide prevention. As a volunteer of the American Foundation for Suicide Prevention in Orange County, California, she chats with people who, like her, are affected by suicide. Hear their real-life stories, learn how they keep living life to the fullest, and find out what can be done to stop suicide. Join the conversation with fellow AFSP volunteers and mental health professionals, all of whom have their own stories about suicide. Let's find hope out of the darkness.
Welcome. Thank you for joining us today. I'm Shelley Pavlis, your host. I want to read you something. Pain is pain. Mental, emotional, physical pain does not discriminate. This is right off the website for Pacific Solstice Integrative Psychiatric Clinic. And here today as my special guest is Britten Devereaux. She is the managing director and she is a licensed alcohol and drug addiction counselor. Welcome, Britten. Thank you so much for joining me today.
Good to be with you, Shell. Thank you.
Thanks. So I think that's important to start with, about pain. And I mean, that's why you're here. You want to help. So explain a little bit, what is an integrative? Am I saying that right? Integrative psychiatric clinic. Okay. What is that? And tell me about your team.
Okay. So starting with pain needs a comprehensive approach. Pain needs an approach and a perspective that takes many things into account. So if you think of it, we are many parts. And with that, the same thing as far as body and mind, we need to keep that at the core of a treatment plan for somebody that needs dual diagnosis care, mental health care for developmental disabilities. So thinking about integrative care, you have physical, mental, emotional, social, spiritual. So you have various components to the human being that help them tick, that help develop personality, preferences, that define our strengths, that define our needs, our goals. So in short, an integrative clinic is one that looks at the whole person and does so with a long-term view or a long-term timeline. We're not looking for short, quick rewards where just a medication management psychiatry clinic would do that.
Okay, great. And your team members, does each practitioner focus on a specific area? And if so, and where would there be overlap?
Sure. So for an integrative clinic, we are interdisciplinary. So everything from a nutritionist to a doctor of osteopathy, psychiatrist, to a physician assistant that's trained in functional medicine, to licensed clinical social workers and associates, to we work with psychological assessment and screening from psychologists, and then myself, a licensed advanced drug and alcohol counselor, all the way over to our neurotechnicians that treat traumatic brain injury, major depressive disorder, OCD, anxiety, any number of developmental or mental illnesses can be treated through the neurotechnician care, which is magnetic e-resonance therapy. It's most well known for its treatment of PTSD and depression.
Okay, great. Thanks. And we will talk about that in a little bit in more detail, because that is super fascinating to me. And I want to talk about the results that you're getting. We want to take a quick break and recognize that today's podcast episode may not be appropriate for everyone. If you are in crisis or know someone who is, please call the Suicide Lifeline at 1-800-273-8255 or text the word HELP to 741-741. And of course, if you feel you or someone you're with are in danger or experiencing a medical emergency, call 911. Before we get to that, I just want to, obviously this podcast is about mental health and suicide prevention, and many who have suicidal thoughts are depressed. So can you explain the difference between major depressive disorder and persistent depressive disorder?
So I can speak to it as far as an integrative approach. That would be something more so for our psychiatrists to speak to from a clinical medical perspective. But I can tell you that when you think of persistent depression or major depressive disorder, this is speaking to chronicity. It's speaking to severity. So for you and I, we're interested in suicide prevention. Clearly, we're both sitting together today. There is similarities as far as how we would treat both of the disorders that you mentioned. So you're citing the DSM, so the Diagnostic and Statistics Manual for Psychology, right? So if you think of how we look at the two disorders, the treatment plans are quite similar. But for us, when we think of suicide prevention, we're looking at persistent depression and major depressive disorder as high risk and in need of whole person care, because a medicine is not going to be the only answer. We need social supports, emotional tools, new mental frameworks, right? We need to look at the environment that the person's in, belief systems spiritually, right? Any beliefs as it relates to their professional needs or academic needs. So if you have persistent depression or you have major depressive disorder with or without psychotic features, either way, you need an approach that takes into account your preferences and your history. So one of the things that I think happens a lot when we talk about suicide prevention is we think, oh, this is a really difficult topic. We'll never really fully get where we want to go with this. Well, I love your goal with changing it by 20% by 2025. When you think about that, that's why you need integrative care, because you need to really get to know the person. The person who's in a depression or anxiety or feels isolated from others, they're not necessarily going to bring up the things that bother them the most, but those things will be there regardless. And so as we go through a medical approach to treat a disorder, we have to really take our time with screening and assessment. And Shell, that's one of the main things that's missing when it comes to comprehensive care, from the primary care provider to the OBGYN, to the specialist, and all the way over, of course, to psychiatry. So we go gangbusters when it comes to screening and assessment. So we can really drill down and treat the person the way that their human dignity deserves.
That's great. Yeah, I think we're getting to a point, hopefully, in society where, and some of the laws that are being passed, where it's required to have more training and more screening. So that's amazing, but we're not there yet. So it's great to hear that you are very focused on that and understand the importance of that. So you do treat all ages. You treat children at your clinic as well. Could you give us a little bit of a taste of some of the programs and treatments that you have for kids?
Sure. Yeah. So to speak to the population, it helps again for us to really point out that death by suicide, right, is something that we're right next to you saying, let's find a way for a person to, as we all know, we have a 100% mortality rate, to have death, right, with dignity, with human connection. So if we talk about human connection, we need to look at the fact that our children and our adolescents, whether we'll go over to millennial, Gen Z, and thinking about what their primary struggle is right now, it's not just attention deficits, self-harm, or anxiety. It's that there's a lack of human connection that they're experiencing because of the screen dependence. And then the withdrawal symptoms that come when a person has to put the screen away and then not feeling a sense of belonging. So we're working with young people because they're highly dysregulated. And so we're going to treat the depression or the attention deficits, but what we're really going to treat is their social need for one another. And they're not going to be able to get that from a small ubiquitous device. They're going to get it through some of the treatments we offer, which is first and foremost working with the family. So the family needs skill development, the whole family. That's hard because a lot of people will call us or come and they'll want one person to get treatment and want to focus the discussion on them. But remember, we heal together. We learn together. We don't go off on an island and say, I'm going to go get things right all by myself. No, that's why we go to schools, right? Why we learn things, why we have team sports, because we were made for connection, for relationship. So fundamentally, the answer to that is everything starts with relationship in our services. So first the family, in skill development for self-regulation, self-awareness, and self-efficacy for each family member. And that looks unique because a lot of individuals right now don't know who they are because screens have changed the way we perceive ourselves and others. Everyone feels so much more distant, isolated, misunderstood, and judged. And so integrative psychiatry, we have a chance to step in on that and to be a really good listener through screening, through assessment, through empathy, but also through practicing the skill with the patient, not sending them off and saying, oh, here's a couple handouts. Try that when things get stressful. Right. Good luck. Call us if you need us. Mm-hmm. It's very practical, the care that we're offering for young people, for children, for adolescents, young adults, all the way up to the geriatric psych community. So it starts with relationship. So that might look like working with one of our social workers in therapy. It might look like case management for relapse prevention skills. It might look like working with an associate or a nurse related to self-harm behavior prevention or intervention so that the family can have dialogue around it. Okay. Our job is it's similar to your mission, to get things started talking, right? Let's start talking. And so we don't require a lot from anyone in that, but we do require some writing, some verbal engagement, and we're all eyes when it comes to nonverbal engagement so that we can support them because no one's really talking about that anymore since screens became so important. The message is so deep in each of those layers. So therapy, it would look like case management. It would look like psychiatry. So our psychiatry is functional med focused or osteopathically focused, you could think of it as, or the combination of holistic plus conventional. Mm-hmm. So our assessments are lengthy. You're looking at 45 to 75 minutes so that we can get all the data. And so are our follow-up appointments. So they're not med management appointments. We don't do that. We have to label some things like that for insurance, but we always over-deliver. So beyond psychiatry, we offer extensions of care for the chronic, persistent, severe presentation of depression or anxiety. One of those treatments is magnetic e-resonance therapy, which is an advanced form of transcranial magnetic stimulation. So what it does is helps neuromodulate the brain so that the four lobes of the brain better communicate with one another. So you have higher amounts of processing, which means you have better emotional regulation. So just to give you an example, think about the person returning from war or the person that just experienced a crime or the autistic child. When they can't express themselves, right? When the processing isn't there, there's going to be behaviors like maybe substance use or a process addiction, or it's going to be verbal outbursts. And what we're telling people is addiction isn't quite what you might think it is, nor is depression. if you take an integrative approach, you're not stuck with any labels. You get to have quality of life. And the big thing that I say in any staff meeting or with any patient is it's micro shifts. It's small changes. It's not big sweeping changes. So magnetic e-resonance therapy would be a service. We also offer a specific service related to suicide prevention to help somebody avoid the ER, just hopefully not even have to stop there. It's called Spravato, and it's manufactured by Johnson & Johnson, and it helps the executive functioning as far as it relates to problem solving when I am having suicide ideation or self-harm behaviors that are increasingly so, where it's becoming less and less of seeing my human dignity and more of seeing how I hurt myself to distract from the pain. Spravato is a nasal inhalation, and that happens twice a week over 6 to 8 weeks in the clinic. And then we offer partial hospitalization, which sounds really, right? But it's 8 hours a day where you come in and you have group work, therapy, you see a psychiatry team. There's art, there's music therapy for the central nervous system. So we call that PHP. And that usually lasts like 30 to 90 days, depending on the chronicity and prevalence of symptoms upon screening and assessment at admission and prior to admission. And then intensive outpatient. So that's something that a lot of people are familiar with when it comes to treating depression, because they think it's not enough for me to go to my therapy appointments or to take this medicine. I need something more. And one thing that we remind families about a lot is lots of times what our idea of something more will be when it comes to mental health will still not be enough because the stigma is so strong. So when we say I need something less in mental health, everybody's like, oh, that's great, you're doing well. But think about it if I said that about exercise or nutrition. I need something less. And yet it's rewarded and celebrated when it's related to mental health. So a lot of people will call us and say, I just need a psychiatry appointment, or I just need to talk a couple things through with my husband. We're not sure if we want to do separation and I think he's drinking. Or they might say, my son is addicted to his screen. He has insomnia and I can't control it. He gets violent with me. And we'll say something like, let's start with an assessment, because there's nobody that can make a decision about what to do next just based on a 10 or 20 minute phone call or face-to-face assessment, because it's usually far worse than anybody wants to talk about it, wants to disclose, right? Because of the stigma, because it's mental illness is criminalized, is alienated, right? Is pushed aside and is misunderstood. So our services for some people might seem like a lot, but believe it or not, most people, once they have depression, anxiety, an addiction of some kind, relational discord, it needs a very full-bodied approach, and it needs integrative care. So that's a quick overview. I could go in more in depth for any of that, but of course, it's my favorite thing to talk about because we do it really well. We're very good at what we do.
Yeah, I love it. And yeah, that was a lot. So I have a couple of questions. So when you're working with an entire family, and one individual in the family is the individual that has the mental health challenges, and you have a family member who is affected or has grown up with the stigma, does not understand really what a mental illness and mental challenges are all about. How do you handle that, and how do you work with that family member too and bring them on board so that the whole family's on board? Did that make sense?
It does. Okay. And it's a great question. It takes a gracious, consistent, and layered approach for every family member, specific to personality, strengths, needs, and their own symptoms. Because most people are rewarded for masking their mental health symptoms, right? Which is why these problems go untreated for generations, and then it affects your mRNA, right? Where trauma, right? The body keeps the score, right? Famous book, but it's true. The body keeps the score on our pain. And so these things just go across relationships and holidays and generations. So we start with a layered and consistent, gracious, or you could say empathetic approach, because they know themselves better than they think they do. And it's usually really hard to talk about yourself in a genuine and authentic way. You usually, the human, right, is prone to talk about the things you think someone wants to hear.
Correct.
And it's our job through a layered approach to talk with them about where they're at now, but really get clear on the vision of where they want to be. And so through mindful daydreaming, mindfulness exercises, dialectical skills, cognitive and behavioral therapy, we help bring the imagination back, and a sense of wonder, and a family that experiences that is a very resilient, connected family. So we start there.
Amazing. Who doesn't want that? Right?
We all need that, right? We all need to take our time each day for visualization and imagination. And it's funny because it's not a Norman Vincent Peale thing, right? It's not a,
Right.
it's a daily thing, because that's how our brain is made, and it needs that. It needs us to see pictures. That's why cinema is so compelling, because it brings things to life. And that's our job when it comes to being a integrated, interdisciplinary mental health team.
And when your treatment is focused on the research and on science and on, neurology, it's the best basis for, comprehensive treatment plan. So
Yeah, it's not a simple path.
right.
And so we have to take a lot of science into account, and then we need to stay up to date on the new science. And that's what keeps us as a team. We're a very close team. We love each other, but part of it is because we're all so passionate to provide the most cutting edge, relevant treatment in the most affordable way. And most people, when you think affordable, you think dollar for dollar, and we're thinking dollar for minute. We don't want people to waste their time in our clinic. We want them to get everything and more for the time that they spend in their mental health care, or I could just say in their health care.
Right. So let's talk a little bit more maybe about MERT. I don't know if you could maybe pick a case study, and so obviously, to keep your patient anonymous, we won't talk about any details of the patient other than the treatment, but maybe you could select someone, or you could think of someone, maybe a veteran, who, has gone through that treatment, and tell us a little bit about what they were like when they first came in for treatment, and then what they're like now.
Okay. So I'll do kind of a merge there. I have two patients in mind, a bit different and yet a lot of similarity. So the one is a victim of war and crime, and she's from the Middle East, and she presented with major depressive disorder and post-traumatic stress syndrome, anxiety that was uncontrollable, and that it disrupted sleep. She had experienced weight gain. She had experienced emotional discord in relationships. She was not retaining information that she was reading. The patient presented as somebody with suicide ideation multiple times per day, but at the peak of her career. Very confounding to a psychiatrist, right? Because a psychiatrist might say, well, let's just change the medication. And our point is neuromodulation, literally a transcranial stimulation to the brain, can actually help her address the suicide ideation, because we're working with the frontal lobe, the problem solving. And we're also bringing what she needs, which is brain rest at night, because the brain heats up and it needs to cool down and rest so that it can process the things from the day, including the trauma from her war and crime experiences. So this individual attends the sessions 5 times a week, right? And over time, through screening and assessment, she notices her screen time's going down. She's looking for less emotional satisfaction from scrolling, looking less intently for someone else to basically validate human existence, because she's able to start doing those things for herself because she's also practicing what she's learning in therapy. Wow. So again, integrated. This patient is also at that time taking medication, right? And the dosing is being changed in a very conservative, careful way. She's applied functional medication to the protocol. In other words, you have supplements, dietary updates. So there's the opportunity for the body to really reset while the brain's doing all this hard work. And mind you, when the brain's doing all this hard work, you're just sitting there when you're in MERT. It's just a small plate that does all of this processing. But this patient, over time, is fascinated because she's never experienced before the suicide ideation decrease, ever, since childhood. She was a victim of assaults, sexually, physically, had seen war and touched her firsthand. And so as she looks back while she's getting these treatments, she explains with great detail how she's able to visualize now and have a sense of imagination and a sense of hopefulness for what might be ahead. Wow. So she's less like a robot and not just repeating the same behaviors like every day to stay at the peak of a career or to look a certain way, but she's actually integrating within herself and then outside of herself in relationship and belonging. So that's one. The other is a veteran gentleman, 55 or 56 years old, presented with traumatic brain injury, post-traumatic stress syndrome, and major depressive disorder. The individual's marriage was in distress, sleep was in distress, insomnia, difficulty falling asleep, staying asleep, didn't feel rested, had no desire to have the same hobbies which he used to with his horses, farm, other recreation, which you would think would be just an amazing experience. And he explained that he would have these flashbacks while driving. And over time, the flashbacks started to decrease. And he was able to apply self-compassion when he had these things that he wants to just push away. So what MERT does is it helps you have the awareness, the rest, right, and the ability to regulate without having to, smoke marijuana every 2 hours or take a benzodiazepine or numb out with some immersive experience on the screen. Where somebody starts to feel a sense of their own dignity because they're noticing their symptoms change, they're noticing their suicide ideation decrease. And again, they're noticing themselves integrate more within themselves, right? And then outside to human beings with whom they want to spend time, the key marker.
Fascinating. So explain in the most simplistic terms, MERT. So MERT, only works on the frontal cortex, did you say? Frontal lobe?
So the plate goes here, but the stimulation engages all the 4 lobes of the brain.
Okay. And what types of feelings or side effects, if any, does the patient feel when they're laying there or sitting there or with the plate on their head?
That's a great question. So it's a stimuli that really does feel like a magnetic stimulation. And for some people who experience chronic pain, initially it's uncomfortable. This stimuli, it's a feeling that they have to adapt to so that they can get the best of the treatment. But as far as pain, no. It's not a treatment that's invasive or painful. It's nothing like the electronic convulsive therapy that people are familiar with.
I was going to ask you to compare it and explain the difference between that and
Yeah.
ECT, because I think that's what a lot of people do think of.
Yeah, so
Yeah.
that's different as far as where that's placed. And ours is guided by EEG, so it's non-invasive, and we're targeting the areas where the person can get the most results the quickest, but we're also pairing it with the interdisciplinary treatment plan and team around them, so that there's therapy and case management for the family and skill building and relapse prevention if perhaps they were self-medicating before with THC or alcohol. So ECT and MERT are in two totally different planes as far as how it operates on the brain. There's no shock.
Got it.
It's a stimuli. And so that's why
individual. So how does that work for the individuals? So you actually do a brain mapping first, and then you do it while they're in the MERT session as well, or how?
So that's correct. We get the
Okay.
picture from the EEG, so the electroencephalogram. We get a picture of where things are at as far as how the brain is currently modulating. And then that is reviewed by a team, a neuroscience team that determines the protocol based on the person's brain, right, and the current activity in the brain. So you can actually tell if someone's in an addiction, if they have insomnia. They can see the chronicity of attention deficits or autistic spectrum indicators. So this is going to help stimulate areas of the brain, so that areas that might be overactive and are overcompensating for other underactive areas, now it neuromodulates and it comes together. So there's the timeline with it is more important than the pain, because you have to do it 5 times a week for 30, 35 minutes, 38 minutes. And that would last for 40 to 60 sessions. So while it's not painful, it's like we said before, we're looking for the maximum output or the maximum benefit for people over time. It's not short. It takes a couple months, takes a few months. Like the gentleman I mentioned to you, the veteran in recovery, he did that for 4 months, but was getting results in the first month.
Fascinating. I don't know, maybe my nerdiness is coming out, but I just think this is so cool. So you're having success with all different types of people. I am probably focusing a little bit more today on veterans, because we really want to obviously increase the work that we do with veterans, and also because they're a target group for us. There's a high number of suicides in the veteran community, and we need to obviously help.
The warrior
decrease those
concept with
numbers.
that,
Yeah.
what you are seeing, right, with the veteran community, I need to get through it and with the minimal impact on others. And we're saying when they get here, we're going to really be focused on you, and it's going to feel funny at first. And so your choice today is, are you going to receive that over a long period of time, a month, 2 months, 3 months of support, or are you going to keep warrioring? Because we love that you warriored. Thank you for your service. We need you. But right now, it's going to be more surrendering and pause, and times where there's no activity and busyness. And that's hard to adjust to at first when you're cared for at that full level of an integrative, right, path.
Yeah.
So we're with you on the veterans. I come from a long line of patriots and veterans in our family. And so we are contracted with TRICARE West to serve Department of Defense, right, service members. So
Fantastic.
military, active duty, military, retired. And I tell you, I love when I get to meet them and thank them, but more than that, love to see them have the relationships, the belonging that we want for all of the ages that we serve. But most certainly when someone's in a mental illness, they're not feeling belonging to themselves or others.
Yeah, and you had so you touched upon how environmentally and how the times create new issues for people, and we're seeing the social isolation and more screen time. People are working from home more, the lack of social interaction, and COVID had everything to do with that, and we don't know if that will ever end too. Now that companies have found that it's actually pretty cost effective for people to work from home, that may continue and people may end up still in front of their screens. I wanted to ask you if you've seen an increase in any issues with veterans with the recent pullout from Afghanistan, and if you've heard how that's making veterans feel.
Yeah, there's great grief and solemnity, a seriousness, and there's fear, anxiety, and it brings things back up in a very post-traumatic stress way, right? Like what they already experienced in life as far as PTSD. So why is suicide so prevalent in the veteran community, right? There's so many answers you and I have to that question, but one of the things is they want to believe that their contribution to the world made a difference. And whether it's this recent decision for the U.S. to depart, whether it's some of our choices in the past as it relates to allies and war, everybody wants to feel that they've made a mark in the world to leave it a little better than they found it. So our veteran community right now is most certainly conflicted.
Yeah, thanks for sharing that. I don't think a lot of people realize the impact that can have on someone who has served. Yeah. So, I appreciate you mentioning that. And we want to support them and do value, obviously, their service and everything that they've done. And we all need to let everyone who has served know that we appreciate them and that they have made a difference.
Yeah, that's absolutely right. And for us, it's like anything, whether it's any part of healthcare or business, you can't guarantee any outcome. Can we live with that? Can we live with the fact that control is an illusion, but give our very best to our own self-regulation every day and to be a force in the world for light? And as you know, some of the decisions that our soldiers have made for us, they were very much a force of light. And people need to see that and celebrate that, because it's not, joining the military and serving your country is not about death. It's not about killing, right? It's about peace and finding it. And we on this side of mental health treatment are doing the same thing for those people brave enough to stand up for your safety and mine.
Very well said. Thank you. We're at the point in the show where I normally do a listener question. So the listener, of course, didn't know that I was going to be speaking with you, with your background today. So what I do is I take listener questions and I actually put them into a conversation where I think that the question, is applicable. So you touched upon this already a little bit, but maybe you could expand on it. So this particular listener question came in through email, so they did not record it. So I'm going to read it. A family member has had a mental health crisis in the past, and I want to prepare for next time. Is there an alternative to the ER depending upon the circumstances?
There is, and there's a few ways to prevent that trip to the ER, because the ER is just trained in different type of emergency. Yes. Any ER nurse or doctor would tell you that. So preventing has a lot to do with what the daily routines are now. And I would say we start with sleep. Where's the sleep patterns? Is there true brain rest for processing? And then we move over to nutrition and movement and relationships. And so we start with these really small areas where we can just make a couple small micro shifts each week, not each day even. And the ER is highly preventable Because if you think about what you're going to get the next time there is a psychiatric emergency or decompensation or a flare-up of some kind as it relates to increasing suicide ideation or homicide ideation, it's medicine alone. It's not a service. There's no therapy. There's really no case coordination from the ER. Maybe if you're admitted to the psych unit, maybe. But even that, because of the mental health crisis, we have a lot at our fingertips to prevent that trip and that cold, very cold experience of sitting and waiting for someone to tell you that you matter by the way that they treat you, provide you with some relief, but the relief will only be momentary. So I love the question because we want long-term relief for the community. We want long-term relief for families. So it starts with sleep. And it's interesting because we can make it about other things like, oh, but he started smoking THC, or he's doing this to cope, or she did that. Let's look at the daily routine as it relates to sleep and then move into the morning routine. And we'll take it one small step at a time of preventing the need to go to the ER when the depression, the anxiety, the feelings of worthlessness, helplessness, hopelessness get unbearable.
I love the preventative, proactive approach. We need to all be thinking about that as opposed to the reactive. Let's keep people out of the ER. Let's prevent the crises. Yeah, that's
the
amazing.
Preventative concept is hard for us to really lay hold of as Americans, really as a human, but particularly right in an immersive experience daily where we can get whatever we want from our screen, right? I can have a filet mignon, right? Medium rare delivered here in a matter of minutes. Delayed gratification is not something we're familiar with or that we welcome, but it's in the pain, the waiting, the discomfort that some of the greatest resources, right, and mental fortitude is developed so that we can tune into sleep and nutrition and movement and the people around us. The challenge lots of times with the stigma staying the way that it is because of the reactiveness that you talked about. So the stigma stays that way as long as we keep reacting and putting off mental health. And the CALM app and an SSRI aren't enough. It has to be an integrative whole person approach. Those are two important parts, but there's more.
Thank you. Of course, today we will put all of Britten's information and information on Pacific Solstice in the show notes and links to everything that we talked about today. I would like to ask you, as our last question here, what is hope to you?
Hope is beyond things relying on me, that there's a God that created me, a maker, and I'm not the one in charge, and that's a really good thing. And so when I think of hope, I think of the fact that I don't have to have all the answers. I don't have to be a world-class, world-renowned clinician or daughter or friend or significant other. It has a lot more to do with doing those little things each day that I know add up to me staying self-compassionate and staying present. And I tend to be more hopeful when I'm those two things. It's more right-sized. I know who's in charge, and that's where my affection points, and hopefully my behaviors, emulate that. But the good thing for the life that I've led is God was able to shake me from trying to be in control of everything. As it relates to my own mood or my own joy or my own accomplishments. But I just take small steps to do the next thing that lines up to my values. And that's hopeful for me.
Thank you so much. Thank you so much for everything that you do, for your conversation today, and for helping us reduce the number of suicides and get people mental health, and for talking about it and removing the stigma. I really
Absolutely.
appreciate the chat today. Fascinating. Thank you so much, Britten.
Thanks, Shell.
If you are in crisis or know someone who is, please call or text the Suicide Lifeline. You can find out how to reach the Lifeline by looking for the numbers in the show notes of every single episode. If it wasn't glaringly evident in today's episode, I'm not a mental health or suicide prevention professional, and this is not an official AFSP podcast. I am determined, however, to find a way to help stop suicide in my community and to support those affected by suicide.
Thanks for listening to Hope Out of the Darkness. To learn more about Shell, the American Foundation of Suicide Prevention, and how to submit listener questions to be answered on the show, visit hopeoutofthedarkness.com.